Okay, so now let's move on to the second session of demyelinating disorder. Let's see how the feeling is when there is something peeling from the body. So let's move on to the demyelinating session. I would like to invite our special chairpersons, Dr. C.S. Agrawal, who is the renowned neurologist working as a senior consultant in Sir Gangaram Hospital, Delhi. Dr. Anjani Sharma, who is a famous neurologist working in a Rukmini Birla Hospital in Jaipur. She has special interest in epilepsy and neuromuscular disorders. Dr. Atul Prasad, Principal Director and Head of Department of BLK Max Super Speciality, who has got a special interest in stroke and movement disorders. So please come on stage. Dr. C.S. Agarwal, Dr. Anjani Sharma, and Dr. Atul Prasad, please. So now I would request my chairpersons to invite our speakers for the respective sessions. Thank you.
Good morning, and thank you very much to the organizers for giving me such an opportunity to listen to some great speakers on the subject. So, is there any need to really introduce Dr. Rohit Bhatia? The answer is no. So, I'll straight away invite Dr. Rohit Bhatia to come and deliver the talk. I'm so sorry. So, Dheeraj, sorry.
By means of a few cases to clarify uh, the entities of NMO and MOG. So NMO and MOG, as you are all aware, have been recent entrants to the neuroimmunology world. And what we have learned till now is there are newer presentations coming up. There is an evolving understanding for both of these disorders. And it is believed that we may still have newer information coming in coming times. So I start with my first case. It's a 51-year-old female, which we recently saw presented with recurrent episodes of sensory motor deficits. And early in June, she had starting of pain in the right calf region, which was dull aching, which later on there was 10 days later a numbness in the lower lip and the gums. And still later, 4 days later, she had left lower limb weakness, both proximal and distal, and then she started requiring a stick to walk. She was admitted at an outside hospital before she came to us. Her CSF showed high proteins, cells, 80% lymphocytes, and the nerve conduction studies also showed, which I didn't write here, they showed a pattern of axonal neuropathy. With the F waves were not absent, but the latencies were prolonged. And patient was actually diagnosed with GBS, was given IVIG and methylprednisolone, and she tended to improve. Her numbness improved. She was able to walk independently. However, just a month later, because this happened in June, so August first week, she again had episodes of dizziness with vomitings, which lasted for 2 to 3 days, and this vomiting was spontaneous. It was more of a kind of a projectile vomiting, and band-like sensation at the umbilical level with bladder symptoms. She got referred to our clinic, and when we examined her, she had good power, 5/5, in the upper limbs and 4/5, and her reflexes were brisk but were absent in the lower limbs. And we went ahead and did the imaging for her, which just a second, I think. Okay. So I'll run it slowly here. So of course there was a clinical suggestion that there's something else happening. It is likely not a GBS. Even in the first attack, when she went on to get numbness in her cranial nerve distribution, there seemed to be something else. However, she did improve with IVIG, which of course in immune disorders it does happen. So if we see carefully in this MRI of the cervicodorsal, there is a long segment lesion here, which is seen in the dorsal region, as well as short white matter lesions in the upper cervical. And also contrast enhanced brain MRI. And if we look at that, I'll go in the reverse fashion. So in the supratentorial region, There are a few white matter spotty lesions here, if we see, in the centrum semiovale, some in the periventricular region also, some close to the lateral ventricles. And in the brainstem, we do see some changes which are apparent, mainly here in the medulla. So we see a hyperintensity here in the posterior medulla as well as, just a second. Sorry. So practically in this region, which is also, I believe you would all appreciate the fact that this is close to the fourth ventricle and in the region of the area postrema, which also fits into the clinical syndrome of the patient. Okay. So the other investigations which are carried out again, we did a CSF which showed lymphocytic predominance, high proteins. The OCPs were negative. The evoked potentials, they gave us a prolonged P100 latencies, signifying involvement of the optic nerves, electrophysiologically at least. Both anti-NMO and the MOG were negative. However, that's how the discussion starts. We now have what we call as core clinical features here with an NMO negative. And if I were to recapitulate the NMO criteria or how we diagnose NMO these days, is to have at least, if the NMO is negative, two core clinical criteria and dissemination in space, which happens, and one of them is a LETM. So this fits into a NMO. The interesting part is, if we would notice that the patient had absent reflexes, and even in the first episode, there was a suggestion of a GBS due to certain findings in the nerve conduction studies. So, would anybody think I could have a raise of hands? Is that odd in NMO, or could it be possible in NMO? Is it odd, or is it possible? Is it possible in NMO? Any hands? Well, okay. Well, this thing was even unclear to me, and this was the only thing which made us think, are we still dealing with NMO? Although we still have an LETM. So I'll come to that later. So patient's treatment is given with steroids. She's improved, and now we're planning to start her on rituximab with the usual induction dose, either the Fujihara's protocol, 375, but we usually use, to make it easy, to 1 gram given her 2 weeks apart, and later on maintenance at 1 gram every 6 months based on CD count. So just to have a recap, for Davik's disease, it was described late 19th century by Eugene Davik. In fact, it was his student who had also written the thesis. And this was based on a postmortem description of a 45-year-old female whose demyelination of the spinal cord and optic nerves gave the name to this disorder as neuromyelitis optica. What is the NMO spectrum disorders? As of now, they have been referred to. This is practically a spectrum of conditions associated with the presence of an antibody, which came in quite late in time. In fact, recent times, the antibody got elaborated. In fact, it's now known as an autoimmune astrocytopathy. The foot processes of the astrocytes, they get damaged, and due to the presence of the aquaporin receptors, and the antibody, which is an IgG NMO or an anti-aquaporin antibody, got discovered by Vanda Lennon in 2004, I think, Johns Hopkins, and this leads on to the damage of the which causes the NMO. And the age is usually middle-aged women, and there's a very high predilection for women. It's 9:1 is the ratio, and the annual incidence is believed to be 0.5 to 0.8 per million. So what is the spectrum? Let's go through the spectrum, which is now being expanded. Initially, we thought of optic neuritis, transverse myelitis, and area postrema, the typical spectra which we know of, brainstem syndromes, diencephalic and cerebral syndromes. These have been described. However, now with emerging understanding, we now know that there may be even a myopathy with hyperCKemia. In fact, reading literature in the past, I remember reading years back this entity of hyperCKemia, and this was, in fact, initially considered under dystrophinopathies. So surprisingly, this has now landed up with an association of NMO antibodies, and it is proof to the fact that the disorder disseminates even beyond the CNS. Myeloradiculopathy. Now, this is the interesting part, and myeloradiculopathy is now known to be associated with anti-NMO antibodies, and this leads on to changes in the cauda equina as well as in the lower cord, in the conus. Neuropsychiatric manifestations and uveitis. So these are newer emerging entities or the manifestations of NMOSD. And if we were to look at our patient, the patient had all three of these, which was myeloradiculopathy, area postrema, and a transverse myelitis. The myeloradiculopathy was what was uh, kind of not expected and seemed odd in that case, but it is a manifestation and can lead on to absent reflexes in the early part of the disease. So importantly, most patients are going to present with transverse myelitis or optic neuritis, around 85% of them, mainly 50%, for example, myelitis, and a small percentage may present with simultaneously with both of them. And the rest of the 4%, around very small percentage, presents with the other manifestations. So to go to the criteria, the classic Wingerchuk, I'm not discussing that because those were initially when MR imaging was not part of it, where we had optic neuritis or transverse myelitis and no other explanation. Those were simple Wingerchuk. And later, when we came to know that LETM was involved, we included in the modified Wingerchuk criteria. Imaging was involved, and then after the advent of IgG NMO, even for short period, the modified Wingerchuk criteria also added the NMO antibody. But now we have the international panel for the diagnosis of NMO and the IPND criteria, as we call it. So core clinical characteristics have to be identified. The core are, just as I explained, optic neuritis, transverse myelitis, and area postrema, brainstem syndrome, or diencephalonic syndrome and cerebral syndrome with NMOSD typical brain lesions. So if these are the core clinical we identify for patients with a positive, we only need one core clinical. That's the important thing to remember, and a positive test. So that becomes like almost diagnostic. And when you get a positive NMO, it's very easy. And you have to exclude others as for usual criteria. And you may even keep a symptomatic cerebral syndrome with NMOSD typical brain lesions as, sorry, that's from the previous slide. So in patients who have negative, as was the case which I showed, you need two core clinical criteria. Out of them, one has to be at least either optic neuritis, LETM, or area postrema, out of the major core criteria. And dissemination in space, meaning it has to be present at two different areas, which got fulfilled in the patient which I showed. Importantly, patients who have negative NMO, IgG NMO, there are certain requirements for the MRI which have to be fulfilled, which is either within the acute optic neuritis, the optic nerve area which is involved should show in the distal part or the posterior half of the optic nerve along with the optic chiasma. And the transverse myelitis requires a long segment LETM, and it has to, usually it involves the entire or a major part of the cross section of the spinal cord. And the area postrema is in the dorsal medulla, which I just showed, and the area postrema lesions. And the brainstem syndrome also involves or also requires the periependymal. So one thing to remember is most of the lesions of NMO, they line up the ependyma. That's one way to identify. They'll be close to the ependymal lining of the lateral ventricle, and these are the ventricles, and these are like typical lesions. You have the area postrema, which extends down to the cervical cord with swelling of the cord. This is a contrast enhancing take up, and this is the optic nerve on a FLAIR image, which shows the posterior aspect getting involved. The chiasma is not seen here, and LETM characteristically seen. These are characteristic lesions. So what are the red flags? So one has to be careful if you get certain features which may indicate that you are not dealing with NMO. If it is acute symptom, it just lasts for, it rapidly increases over hours. if it is chronically progressive, and you have coexisting disorders, just like the principle of parsimony. If you have an underlying disorder, you should think and talk of consider other underlying disorders. An MRI lesion which shows a gadolinium enhancement which lasts for over 3 months, and oligoclonal bands. So oligoclonal bands is a very confusing part here. We ourselves face this dilemma. A lot many times an LETM would actually look like NMO, and you would get OCB. So OCB, although mentioned, if you get OCB, you may be dealing with non-NMO, but around 15% of NMO will have oligoclonal bands, so you need to use your clinical judgment for that. So the imaging spectrum, like I just mentioned, these are important to remember for the clues if you get any of the NMO associated disorders. So these are the diencephalic around the third ventricle, hypothalamus, thalamus. And this is important because the callosal involvement, if it is there, it's like a bridge arching of a bridge. So this is very typical and helps us distinguish MS. Then involvement of the internal capsule, and this kind of an involvement of the internal capsule, a longitudinal, in fact, it's a longitudinal involvement of the even in the brain, and this is like an tumefactive demyelination, which also is seen in NMOSD. So treatment, I won't go into the details. We all are quite conversant. The off-label favorite rituximab of ours, and a lot of these patients of NMO do respond. However, a few may have relapses even with rituximab. And there are certain off-label, most of the treatments which we've been using all these years since the time we were treating NMOs were off-label, which we still resort to is azathioprine, MMF, and methotrexate, cyclophosphamide, and the newer agents which have very good clinical trials done, and these have now emerged as very good agents for resistant, because and there are different agents which are useful in NMO positive or NMO negative. For example, eculizumab, which is a very expensive drug. This was one of the earliest uh, tested in clinical trials, and it was highly efficacious. Now the new ones are satralizumab as well as inebilizumab, which have been tried and are highly effective. In fact, tocilizumab had a recent study where it was effective in both positive and negative. So that would be one not doesn't have a very large RCT, but could be useful in patients who are either positive or negative in both spectrum. So I'll just rush through this second case. I have less time. A 46-year-old female presented with right frontal retroorbital headache with uh, rapid deterioration of vision. Fundus showed temporal pallor and acuity of 6/9. The MRI showed with optic nerve cuts involvement of the optic nerve, chiefly in the anterior region. We see this bilateral, very, I would say, kind of nodular involvement is very characteristic. The spine MRI was normal, MOG is positive. So we have this a very characteristic picture of a anti-MOGAD, the myelin oligodendrocyte glycoprotein associated disease. So MOGAD is, like I said, it's even still a newcomer. We knew about NMO since 19th century, but MOGAD is just very recent. In fact, the first recognition happened 2015, and initially it was thought it's a subtype of NMO negative disorder, but now we know that this is a distinct antibody associated disorder, and the usual spectrum is ADEM, recurrent optic neuritis, and autoimmune encephalitis. You can think of all the cases you saw all these years. Maybe you were dealing with MOGAD and you didn't identify. I personally remember treating many creons which were chronically relapsing optic neuritis. We responded very well to steroids. So now we think that they may actually have been MOGAD in the past. So immunobiology, I won't go into details, but basically it's a perivenular and confluent white matter and cortical demyelination. Axons remain intact in this, and the attack is on the oligodendrocytes, as the name suggests. It is usually relapsing. CAT could be monophasic. The range is wide because of multiple papers, and the major differences between the two, aquaporin and MOG, is basically the site of damage is astrocytes versus oligodendrocytes. Here, the male-female ratio is not very uh, distinct, or sorry, disparate as it is in MOG, sorry, as in NMO, 1 is to 1.3. Usually the outcome is very good. In MOG compared to NMO, you may have a poor recovery. Relapses are less. It's more in the lumbar region. Optic nerves is lesions, anterior versus posterior, along with chiasma in the aquaporin 4. OCD, optic nerve swelling may be there. In fact, the periependymal rule one must remember for NMO, whereas here you have fluffy more in the thalamus and pons. And the median age is early to mid 30s, has a bimodal pediatric as well as second peak in the young, optic neuritis being the commonest. In fact, multifocal presentations are quite common, and the unique features one must remember is the headache. So pain is always a feature in MS. So we can remember that even M and M, MOGAD, will have pain, but this is headache, and this usually precedes the optic neuritis. And disc edema and hemorrhages, if you get them, think of MOGAD. Usually we don't get them in MS or NMO. And recovery of acuity is usually better for MOG, despite the apparent appearance of a severe involvement. So just a last case, I'll finish quickly. This 31-year-old male, headache of 14 days, which was followed by fever, paresthesia on the left side of face, positional vertigo, dysphagia, but basically multiple cranial nerve palsy, evolving rapidly over 1 to 2 weeks. And the patient's MRI revealed this hyperintensity again in the area of the pons in the middle cerebellar peduncle and the upper medulla. We did all the tests, nothing was positive. NMO negative, MOG negative. In fact, this was a I would call a post hoc diagnosis, because when I followed up the patient a year later, this was seen at the time of the discharge. The patient was given a diagnosis of demyelination, was administered methylprednisolone. He recovered slowly and completely. So we recap, the two core clinical criteria are not there. There is neither an area postrema. There is only a brainstem syndrome. However, NMO negative, so it doesn't fulfill the NMO criteria. After 1 year, we repeated his MRI. It was almost clear. There was nothing. So looking at everything, what we thought and what we still are thinking is a Clippers case, because there was no relapse. There was complete disappearance. And the area of involvement was like Clippers, and there was a nodular enhancement on enhanced imaging. So Clippers and MOG has actually been described too. Sean Pittock had described Clippers in 2010. Anti-MOG antibodies have actually been identified in a few Clippers cases. And remember, just to recapitulate MOG at the end, so these are the typical MOG involvements for optic nerves, anterior 1/3, remember those, and cortical hyperintensity. So this part of the cortex is more bright. So because this causes cortical demyelination, subcortical demyelination, MOG. And you have leptomeningeal involvement. So these are some of the findings that you may get in MOG. Treatment is again steroids, IVIG for resistant cases. There is no evidence in MOG as of now. It's still accruing. There are no clinical trials. You could try all of these agents which you try in NMO. And to conclude, both of the NMO, SD, and MOG are emerging disorders. We still probably don't know the full spectrum of what they cause. And they represent a pathophysiologically distinct class of antibody-mediated CNS demyelinating disorders. In fact, these are true autoimmune disorders. If you compare them to MS, which is not autoimmune, you don't know the target, you call it immune-mediated. That's why we are still using DMTs. Here you're using immunosuppressants, and you almost lead on to a cure of the disease. And the full spectrum, as I mentioned, is still evolving, and we might see newer phenotypes as we have seen in the last couple of years, which have emerged for MOG. Thank you.
Thank you, Dheeraj. Only one question and no dialogue, please. Yes, sir? Mics.
That disappearance of the lesion has never been a feature of multiple sclerosis, or as you are telling in MOG. And the patient come, go, treat it, get well and all that.
Sir, mic में बोलिए sir.
Yeah, sir, sorry. So, do you think that this is a criteria for treatment, that lesions have disappeared is a criteria for MOG? Because this has never been a feature that lesions disappear.
They never disappear in MS, agreed. Because MS leaves behind its footprint in terms of damage to the axons. What I was trying to show was Clippers, where the lesion had almost disappeared. And even in conditions of NMO and MOG, you may have almost near disappearance. If you see an LETM on follow-up, the lesions may actually go off and may become shorter leg segments. So it's always good to image as soon as possible, especially area postrema. Area postrema disappears, area postrema lesions. So if you have a suspicion, image immediately, and localize the area postrema because they may disappear.
Can I ask a question? Can I ask a question?
Sure.
One is what is the peculiarity of area postrema that the anti-aquaporin antibody attacks it? Second is how long do you treat with immunosuppressants patients of NMO?
Right. So again, these are unanswered questions. For the characteristic of area postrema or hiccups, patient comes with hiccups, vomitings. These are the main two features which you would hiccups and even dysphagia is not there, but mainly it's hiccups and frequent vomiting, which will go on for a few days, like our patient also did. So that's an area postrema classical syndrome. And diencephalic causes drowsiness, sleepiness, that's usual. For the treatment of this long-term treatment, it's recommended to look at the antibody status. If you have a IgG NMO status positive, those usually is believed to require longer treatments. And people have gone on to treat for over 2 or 3 years. You can then probably, after an induction and treatment for at least 1 to 2 years, if the patient is stable with no new relapses, you could step down to the other agents like MMF or azathioprine. But there is no hard and fast rule again. Although we say it's treatable, you almost treat the patient, but when do you take off? Because in our own experiences, we've taken off patients, so people have stopped taking it, they get a relapse after even 5 to 7 years if they've stopped the immunosuppressants.
Thank you, Dheeraj.
Sir, what's...
Thank you.
Yeah. Now we move on to the second talk of this morning session. This is to address a very common practical problem in management of multiple sclerosis, which we come across in day-to-day clinical practice. That is there on the multiple sclerosis, how to define treatment failure and how to timely switch to high efficacy DMT. To address this issue, I request Dr. Ravi Anadure to present his talk.
Thank you.
Dr. Ravi is working as professor and consultant at AHRR. He had many honors and awards are to his credit. Dr. Ravi, please.
Thank you very much, sir. Thank the organizers for inviting me and warm greetings from Army Hospital. My job today is to try and define treatment failure and time the escalation of DMTs in MS. This is an area which is a tough one to actually define in terms of simple numbers. So I'll try and give a little background as to how MS evolves and what are the variables you have to deal with when you try and define treatment failure. This is the conventional understanding of MS we had till about 2 decades back, that this is a disease which has a preclinical stage when the person is harboring some kind of a low-grade inflammation in the brain, then he manifests as a CIS or as an RIS, then he starts having remitting relapsing disease for a few years with or without treatment, and then ultimately goes into a secondary progressive phase. That is what we thought, but it's not that simple. And now in the last decade and a half, we have now realized pretty clearly that it is not a disease which has got compartments. There are multiple things happening at the same time, and it's pretty clear that there are 2 more entities which are not very easily visible clinically, but going on in the background. And that is brain volume loss, which also is equal to axon loss, along with the inflammation. So while inflammation is what brings the patient to the doctor and results in episodes of relapses or remissions as we treat, there is ongoing volume loss in the brain, that is atrophy, and axonal degeneration, which starts happening from day 1. So therefore, an obsession with just looking at relapses or just looking at MRI is probably MRI white matter lesions may not be the answer to define treatment failure, and we need to carefully look at brain volumetry and axonal loss as we try and define treatment failure. There's a new entity which has been described now in the last 5 years, and that is called PIRA, that is progression independent of relapse activity. This is an important entity, and we need to understand that when somebody accumulates disabilities, it is not only connected to the relapses, that is called relapse associated worsening or RAW, but there is also something called relapse independent progression. And this probably is more related to underlying brain atrophy or axon loss. And now there are studies which have actually shown that it may be as high as 80% of the disability that a patient acquires. So we need to watch out for this entity. At the ultrastructural level or the chemokine level, if I have to show you the picture, these are two cartoons from NEGM, and I like to show these in my presentations because I find they beautifully bring out the concept behind MS. Here are a few lymphocytes, both T and B cells. We still don't know how, but they get activated in the bone marrow, interestingly. But then these activated cells move on to the brain circulation, adhere to the endothelium, to the blood-brain barrier, and then transmigrate into the brain, which should not be happening. So the entire disease process is connected to activation of lymphocytes peripherally in the bone marrow, and then their transmigration by attaching to the blood-brain barrier into the brain. And there they unleash a whole host of chemokines or cytokines. We can name any one of them. The primary attack in the acute phase is usually onto the myelin, and that's why you get demyelination and you get acute episodes. The other picture on to the left is actually trying to show that when the attack is on the oligodendrocytes and the astroglial cells, that is when you have atrophy and axon loss, because the oligodendrocytes cannot remyelinate, and the microglial cells are essential for maintaining integrity of all the long tracts. The article from which I took this was an NEGM article which came in 2015. But thereafter we've understood that it is not that there are two compartments. That article tries to say that demyelination happens early in disease, axon loss late in disease. But now we know both these are happening together. And when you translate this to imaging, what we see as white matter lesions or demyelinating plaques in the classical periventricular or pericallosal or juxtacortical are actually the acute demyelinating lesions. But what we see now in follow-up MRIs, that is volume loss and chronic degeneration, that is what suggests the underlying smoldering inflammation. We need to watch out for both when we think of treatment failure. Now, there are three models of treatment that are followed by and large in most practices. The first one is what most of us do, and about 80-90% patients probably, we go with a slow escalation model. That is safety first, use the low efficacy DMTs, standard platform therapies, and then as a patient starts showing the disease activity despite these, you slowly go up to a more efficacious but less toxic therapy. And then finally, 5 years, 10 years down the line, probably, you escalate to the higher efficacy therapies. This is fine when you want to keep safety first, and this is what is probably practiced. But of late, we have realized that all MS are not the same. You can have high disease activity right up front, and you need to probably escalate therapy even at baseline. So it's important to remember, based on the cartoons I've shown you earlier, that high disease activity can superimpose any MS right at presentation, in between or later in the disease, and therefore we should be ready to escalate quickly when there is a need. I'll try and define those criteria later. And the third concept which has come in recently is induction, or hit hard first. And this is irrespective of what is the inflammation, just like the hematologists do when you deal with a malignancy. If you're supposed looking at a myeloma, the first step is to try and establish remission. So you get hit hard initially, get control over the disease, and then maintain with a certain drug for a while, and then do a BMT and reboot the bone marrow. I guess we're going to go in that direction subsequently in MS as more evidence accumulates. But as of today, probably induction therapy is best done with drugs like natalizumab or rituximab, which we have, or almatuzumab. This landscape of MS drugs keeps getting more and more confusing because more drugs are being added. We have more than 17, I think more on the horizon. But I've circled off the ones which we commonly use in practice. There are injectables which came in the early 90s. And then we have the orals, riflonamide and dimethyl fumarate. Most of us use DMF pretty routinely, and we know it's a pretty good drug. And among the injectables, we have natalizumab, almatuzumab, and I've circled rituximab because this now has become a fairly commonly used drug in MS, although it still remains off-label because ocrelizumab is what is approved. But it's a chimeric antibody which acts similar to what the humanized antibody does. And we are pretty okay with rituximab now in MS. Although it's off-label, patients opt for it. Ofatumumab has just come in recently in the last 1 year, and I think this will be a good drug which will fit somewhere in between the platforms and the escalation therapy. So that's where we stand today. The injectable first lines are generally the interferons and glatiramer, and maybe ofatumumab. Then you have orals, which I just mentioned. Among the continuous therapies, we have natalizumab and rituximab, and among the non-continuous ones, on which I think Dr. Matthews will debate later, is almatuzumab. Cladribine also is a kind of one-time therapy, but remains in oral therapy, and efficacy-wise we still don't know and not easily available. But I guess ofatumumab will probably move from a platform to somewhere in between. I thought this slide is important. Among the interferons, the best annual relapse rate reductions, ARRs is what we generally look at. PEG interferon has the best, that is interferon beta 1A, at just about 36%. Among the orals, DMF is the best. And among the injectables, although natalizumab looks very good because this is when you compare it to the placebo, but all the ALMET studies were against ongoing therapy, so therefore it looks a little lower. But almatuzumab also, when you compare it just placebo, may probably have a higher value. So these are the higher efficacy therapies, which options we have. This is a slide which I wanted to tell you that when you look at defining treatment failure or trying to switch therapy, one must remember that every drug has a certain window period to be fully effective. I think we should not jump the gun if you're still in the window period when the drug is not fully effective. The drug which is the most effective early on is natalizumab. So when you're trying to deal with a high disease activity, I guess this is one of the best drugs to use because easy to give, and within 4 weeks, it completely blocks entry of all the peripheral lymphocytes into the neuraxis, and therefore probably at 1 month that is fully effective. The others, especially the platform therapies, and including ocrelizumab and rituximab, require a little longer time. It's about 2 to 3 months, and therefore trying to define treatment failure, one should be careful. If the breakthrough happens in the first 2 or 3 months of initiation, it's probably a residual activity of the pre-existing disease and not a breakthrough. A true breakthrough would happen after the drug is fully effective. Glatiramer is probably the weakest drug, has the longest time to be effective, so therefore least used these days, except say in pregnancy. And among the newer ones, the T and B cell therapies take the longest time to be fully effective. It's close to 1.5 to 2 years. So one has to be careful to watch these timelines before trying to define treatment failure. Another thing is, what are the candidates who are likely to have treatment failure early in therapy? Ones who have an older age of onset, cognitive involvement at presentation, multifocal, that is involvement of motor, cerebellar or sensory or a mixed presentation, sphincteric involvement at presentation, high lesion load, especially more than 9 lesions, supratentorial or multiple brainstem or cord lesions, or brain volume loss at presentation. These are the red herrings. If you see these, you're probably dealing with a disease that's likely to be highly active. We need to be careful. At follow-up, there are certain risk factors which tell you that disease may be heading into high disease activity. If you have a second attack in less than 2.5 years of initiating therapy, EDSS becomes 1.5 or more very quickly. Motor symptoms repeatedly at relapse, infratentorial lesions appearing early, and brain atrophy again. So when you see these parameters, one need to get alerted that we are probably going to deal with treatment failure in these subset of patients. We need to be more careful and monitor carefully. Everything is about timing. In MS, it's about getting it right. So if you don't time the switch right, you'll probably miss the bus. And from having a situation where you can plateau a disease, you would have significant disability accumulation. Now let's look at some guidelines. The most recent ones are European and American Academy of Neurology for switching therapy in MS for treatment failure. If you look at the European guidelines, both these are pretty broad-based actually and do not give out very clear cutoffs as to when to define a treatment failure. But both in common have this similar sound that the decision making while switching has to be shared. You have to discuss with the patient all the options and make sure that you get the patient on board, and safety and efficacy have to be balanced, which is fine. Most of us do that. And then they say, if you have to switch, always switch from a lower efficacy to a higher efficacy. Please don't go back, whether it's a lateral switch or an upward switch. And that's why you got to know the efficacy. And in considering switching, they are broadly saying that look at the disease activity. They've not laid down any parameters. Look at the half-life of the drug so that you don't switch before the drug is fully effective. And look at the potential for rebound, especially drugs like natalizumab. For switching, you should be careful that you don't give a long gap. Otherwise, you can have a rebound before the other drug is fully effective. The Americans have a little more precise in trying to define treatment failure. They have actually given some number of lesions, number of relapses. They say as far as disease activity, if you have one or more relapse or 2 or more new lesions on MRI within the first year of therapy. So they're the first people who try and give some numbers to it. So if you have started a treatment and you find that within the first year of therapy, the patient has more than 1 relapse or more than 2 MRI lesions appearing, either supra or infratentorial, then you may be looking at a treatment failure. Then they say other issues which can cause a switch in therapy could be safety and tolerability, which we all know. JC virus and natalizumab, adherence issues and injection fatigue could cause a switch. Neutralizing antibodies, although we don't do very commonly in our practice, and they are still controversial as to we should do them or not. In the American Academy, they do recommend that if you have very high NAb titers going up, you might think of switching laterally to another form of therapy, which is equally effective. Pregnancy, of course, will warrant a switch in therapy depending on what drug the patient uses. So both these guidelines have similar kind of a sound, that you actually balance safety and efficacy. Do not preempt switching by switching during the period when the drug is not fully effective, and try and identify disease activity which is not acceptable. And the guidelines in the American Academy have given the number of lesions and number of relapses. But I wasn't convinced that's the best way to look at it. And if you go a little back, this is a nice article which came up in MS Care way back in 2002. But Bashir et al. From Canada actually first tried to show a model which is called an analog model as to how we can use relapses, progression, and MRI to have 3 different kinds of situations. That is, you have a situation which is to be notable, worrisome, or actionable. So they laid down actually number of types of relapses, and recovery from relapse, and tried to define as to what is notable, worrisome, and actionable. Same thing in progression, similar thing in MRI. A year later, the Canadians actually adopted this in a slightly modified way and came up with their own modified analog model to define treatment failure and how to go about applying these criteria. So what they did, they just changed the name to low, medium, and high. Instead of actionable or not actionable, they said low, medium, and high. They gave three cutoffs in relapses and progression. They removed the high part in the MRI. They felt that using only MRI lesions to define treatment failure probably would be an overkill. And I didn't want to leave it to the radiologist to tell us or to tell them whether to switch or not. So this we'll remove the high in MRI. So they only had actionable or high ones in relapse and progression, and they had only 2 echelons in MRI. Now, what were these? If you look at how they defined the levels of concern, it was quite intricate and complicated. I'll just go through a few. Let's say severity of relapse. They said it could be mild, moderate, or severe, and how they define mild. Steroids not required, steroids required, or steroids required with hospitalization, which is okay. Minimal effect on ADL, moderate effect on ADL, and severe effect on ADL. How many functional domains were affected? One, more than one, or again more than one, and whether there was a motor cerebellar involvement, yes or no. So combining these, they made it into mild, moderate, or severe. Similarly, they said recovery, whether it is complete, incomplete, or delayed. So this was as far as relapse is concerned. Similarly, they had cutoffs for EDS disability using EDSs, that is EDSs 0 to 3.5, between 4 and 5, and then more than 5.5, and then thereafter again multiple points for deciding low, medium, or high. For MRI, there was little more clarity. They use the standard ones, which we also look at: new GAD enhancing lesions, new T2 lesions, enlarging T2 lesions, new T1 hypointense lesions, or enlarging T1 hypointense lesions, or atrophy. And here they removed the high. They just said you could have any one new lesion among these. It's a low concern. More than one in different categories, it's a high concern. What they realized is when they applied this clinically, it was difficult. In research settings, it was fine. But clinically, to go through all these and then decide whether it's actually a treatment failure or not, and to use these in combinations was becoming a bit difficult. So they themselves modified their criteria in 2020. And I find this is the one which comes the closest and the best to help you put some numbers and understand whether your patient is doing well on a treatment or is failing treatment. So here they simply took out the low, medium, and high. They just made 2 categories, minor and major. And they have kept the same variables: relapses, severity of relapse, recovery from relapse, MRI. And what they have said is, if you have any one major of these criteria happening in a patient while on treatment, after the treatment is fully effective, you may consider treatment failure and switching. What are these? So more than two or more relapses in the first year of treatment. In terms of severity, moderate to severe. Any functional impairment after an episode, motor, cerebellar, brainstem, or sphincteric involvement, which we all know are bad prognostic markers. In recovery, if it's an incomplete recovery, residual functional impairment after an episode, and EDSS more than 1, change at 6 months. And here they've given a star that if it's baseline EDSS is 0, then it should be more than 1.5. That is, people with low disability need a higher change to define treatment failure. In MRI, they just removed everything else and they said 3 or more new lesions are good enough to define treatment failure in the first year of therapy. The star here is for spinal cord lesions. They have of late added spinal cord and brainstem lesions, even a single lesion, as a matter of concern when you're dealing with a patient who's likely to fail. I guess they've still not incorporated brain volumetry and cognition into their criteria, but from whatever we read now, from presently published research, very soon these two will also come in as important markers of, probably early markers of treatment failure. Because volumetry is something that depends on a software and requires a trained radiologist to actually give you correct volumetry sequentially. And also cognition, that does require a little bit of time and repeated testing. So these two are the ones which are going to now come in subsequently. But as of today, as of 2022, the only criteria which have been given out clearly as a guideline, again, these are guidelines, these are not clearly laid criteria. Every clinician is going to use his own discretion, but you can look at these as a broad guideline to define failure. As far as minor episodes are concerned, they said 1 or 2 minor variations need not get us concerned. But if we have 3 or more minor and you have another major which does not meet the major criteria, you may then consider switching or treatment failure. So in the end, I guess the best way to put this all together is a game of chess. All neurologists probably when deal with MS are going to be dealing with a chess player. Unfortunately, the chess player here is MS, and it always gets to play white because it makes the opening move. And we then have to decide using the available tools that we have. So if you see here, in the first line, I have tried to lay out all the conventional first line therapies, which are the pawns in our chess. And then you have the heavy ones behind, which are the second line therapies. And depending on what the opposition does, you got to make your move. So let's say it's a convention pawn opening by the MS, then we also go with the Sicilian defense and move your pawns forward and try and see how you can defend and buy time and maybe go for the middle game or the end game later on. But when you find that the opponent is making a difficult one, now this is a knight's move. If the MS opens with a knight, now this is a queen's knight move, which has to go up against a king's knight move. So here you're dealing with a Petrov's defense. So you're going to now launch something higher than what normally would have happened. I guess MS has the advantage when it comes to openings because it always usually has the upper hand on us. But the smart neurologist is one who can anticipate which way a move is going and then calculate the end game and close down the game before MS is able to. So our king is always a patient, and we want to get keep our patient safe and deploy a maximum arsenal possible so that we don't have a situation where we have maximum disability. So my last slide, it's going to be dynamic chess strategy. As we move forward, it's going to be a dynamic strategy. And I took these pictures from a published article by Boschmann et al. From Germany, Dresden. And very nicely, he's brought out this chess strategy. And then he says, actually, it's very easy to play chess because there are only just about, I think, 48 quintillion moves or whatever is possible. But there, by and large, you have worked out everything. Most of the experts in chess know which game is going where, minor a few variables. But we still don't know much about MS, and we still don't know exactly which move is going where as to when the disease might suddenly escalate or downscale. So therefore, it's a very tough game. In fact, neurologists will be dealing with MS more and more because imaging is going to make it more easy to diagnose. And we need to keep changing our position, keep understanding MS as it evolves, and ultimately find the fine balance between controlling the disease and not harming the patient. On that note, I'll end. Thank you very much.
Thank you so much, Dr. Ravi, for excellent and comprehensive review of the subject. Now we can have any question or comment from audience.
Sir.
Allopacentic variant of the MS. So what is the natural history and how do you follow?
So bilocacentric MS or the aggressive forms of MS which are presenting upfront with very high disease activity and severe deficits, they basically are treated as high disease activity MS. They will have to be treated very aggressively upfront with usually one of the monoclonals. Generally, I find in our practice, natalizumab to be an excellent drug to be used upfront for many reasons. Firstly, in the first 2 years, safety is not an issue. Second, it is the only monoclonal antibody which becomes effective within 3 to 4 weeks and gives you very good control of the disease. So in such situations, high disease activity MS is what we are looking at. We should hit hard early, try and gain control of the disease early. And then once, maybe if you can maintain natalizumab, great. Otherwise, most of these ultimately, as we move forward, will end up in a situation where once you buy time, you will go for a definitive therapy, which would be like almatuzumab or autologous bone marrow transplantation. I didn't touch on autologous BMT. I think it's a very, very promising therapy, but it is still in the stages of being researched on. But we have seen quite a few patients do very well. These are all off-label BMTs. I think we wanted to start this project in RNR last year, but COVID didn't allow us. AIMS has beaten us to that. They have already started in enrolling patients. In a few years' time, we will definitely have answers as to where BMT is going. I guess in all these high disease activity and aggressive forms of MS, early hitting hard and achieving quick control of disease and then rebooting the bone marrow is the only answer. Otherwise, you're dealing with disease which can be very fulminant later on. No, sir. It also known to relapse. Very few. If it's monophasic, you're looking at an ADEM-like disease, then probably we are misdiagnosing that as MS. Otherwise, by definition, these MS forms are aggressive and can land up with severe deficits.
Thank you, sir. So my question is that there are patients, say, follow-up of say 20 years, 25 years and all that. Now they are on retinol. But now again they present with relapse. This keeps on happening, not that
So,
say.
please use the mic.
Good, yeah.
Yeah.
Yes.
Thank you.
So what should be the strategy here? In such cases where a relapse has occurred, patient is already continues on to be retinol.
So I'm actually not able to hear you clearly. I guess your question
Yes,
is...
I'm saying for that matter, the patient is already on the therapy of retinol and patient had relapse. So we had nothing but to start with hydrocortisone again, gave for 5 days, and patient improved, the relapse improved. But lesions, of course, continue.
So exactly, I didn't touch on the acute therapy. I think acute therapy of any relapse remains the same, irrespective of when the relapse happens. What we are looking at essentially is the residual disability after a relapse and what kind of a lesion load is there on the imaging and how frequently relapses are occurring. These are the three things which we need to look at. And as I gave out in the guidelines, if this is happening repeatedly within the first 1 year itself, you need to escalate therapy. Escalation and switching is a little difference. When you switch therapy, generally you switch laterally. You switch to a similar kind of a platform therapy with a different mode of action with a similar safety margin. When you escalate, you're trying to use an aggressive form of therapy with a lower safety margin but high efficacy. In the situation that you're saying, by and large, most neurologists would wait for a few months and then see if the drug which he's on is fully effective. I think it's a good time to escalate therapy to a higher form of therapy. And ultimately, we'll all gravitate towards endpoints of therapy. And I guess in diseases which are very active, we'll have to go in for rebooting the bone marrow. You can do it chemically with almatuzumab. You can do it physically by doing a bone marrow transplant.
Sir, any update on the regenerative therapy?
Sir, nothing as yet which seems to work except for aggressive rehab, but I am not aware of any drug that helps in regeneration of nerve cells or myelin. Not aware.
Thank you.
Thank you, Dr. Ravi.
Thank you, sir.
Thank you very much. I always say that life was easier when we were doing a DM. We didn't have so many drugs, and we just used to diagnose. Now we have so much choice, we don't know where to go. Anyway, the next talk is by Professor Satishchandra, my teacher, my mentor, my very close friend. And he'll be talking about jumping into the pool of controversy, COVID vaccine, and neurological disorder. Sir.
Thank you. At the outset, I thank Arun, Garg, and other people from Medanta for inviting me to talk about this pandemic which we are going through still. We are meeting here after 3 years. That itself shows what we had gone through. We initially thought it was only a pulmonary disease, but we know there is a lot of neurology there. And hence the topic, COVID neurology, and also vaccine and its problems. This quote from William Osler says what the pandemic was. It was in January of 2020 when WHO declared that there is a pandemic in this globe. We all woke up and one fine day we started seeing what is happening. I should pay homage to many of my neurology colleagues who have sacrificed their life because of this pandemic. And we all know that one or friends or our own family member have succumbed to this illness. And that is the pathetic situation we were in. This is all because of this virus which has affected the whole globe. Coronavirus is not new. We had coronavirus in the form of MERS, we had SARS, and now we had COVID-19. And we may have many more in the years to come. Don't forget about this COVID-19, thinking that it is already over. We may land up in COVID-23 or 24, whatever it is. So be aware of what are all the things which can come. And that is why the neurological manifestation as a neurologist is very, very important. SARS-CoV-2 enters the human cells through the interaction between the spike protein and ACE2 inhibitors. And these receptors are located in the various parts, the cerebrum, the retina, brainstem, cerebellum, and olfactory mucosa. And that is the reason these things, concentration varies and the affection also varies. Let us look at the nervous system and what happens. The neurological manifestations can be divided into two groups. One is CNS, another is PNS. Both are affected. But there are certain common things and there are certain uncommon things. The common things in the CNS, I'm sure many of you know about insomnia, headache, hypoxic encephalopathy, and stroke. But uncommon things are many more, which could include epilepsy, encephalitis, meningitis, PRES, cerebrovenous thrombosis, and myelitis. Similarly, in PNS, we have myalgia, we have anosmia, we have ageusis, and then visual loss. But uncommon are also seen, that is isolated cranial nerve palsy or GB syndrome-like presentation, Miller-Fisher syndrome, myositis. These are classified variously because of the lack of time. I'm not going into the classification. But what is important is the pathogenesis. At what stage the disease, the neurological manifestations can occur. The early infection phase is one of the phases, that is the inflammatory response is localized to the mucosa of the upper respiratory tract. Then comes the pulmonary phase, the virus proliferates and invades the lung. Then the third is the cytokine storm, which we are all worried about. And the last phase is multi-organ failure. Here is a curve which is against the clinical presentation and the days of presentation. And one need to be aware of it till the disease is over. The WHO defines the COVID neurology as confirmed, probable, or suspected based on the criteria now. And these are the criteria which we use to say whether it is a confirmed COVID neurology or it is suspected one. COVID and anosmia is very well known, and the first 2 months everybody understood about anosmia. And how common it is as high as 60% of the cases, and it was first reported from Germany. The worldwide prevalence now says that it is as high as about 44.1%. And regarding the taste, it is seen in 43.3%. And chemoreceptor involvement, whether it is the smell or the taste, is seen almost in 50% of the cases. That is what is the clue for us. And that is very, very important because this is useful in the early and otherwise asymptomatic carriers of the novel coronavirus. Therefore, it might indicate the infectivity and spreading of the virus. The COVID and headache is a very common manifestation, but we should know that headache in cases of COVID infection may be a very major issue, and it could be bilateral, long-lasting headache and resistance to analgesic. And when it occurs with anosmia and ageusia, always think about the neurological involvement and the headache. Here is a comparison, a study which has been done with a non-COVID and a COVID. What we can see is the last line which I want you to concentrate. The new onset headache is seen in 33.2% of COVID patients compared to in a non-COVID it is only about 12%. So there is a significant difference in the headache. This is very, very common. All of you have seen the stroke and the COVID-19. And initially it is as soon as in 2020, we all learned that stroke is one of the common manifestations with the COVID. Why does it occur? It occurs because of the two important reasons. One is the SARS-CoV-2 enters the AC2 inhibitors, and then it decreases the AC2 receptors in the lung and then producing the inflammatory response and cytokine activation, which results in increased D-dimer and prothrombotic state, and which along with the other risk factors leads to the stroke. On the other hand, it can also goes through the hematogenous dissemination with vasculopathy and developing an ischemic stroke or hemorrhagic stroke. Both are very well known to occur. So the presentation of stroke could be venous occlusion, or it could be arterial or multiple arterial distribution, or microhemorrhages, or watershed infarcts. And the pathophysiology is coagulopathy, antiphospholipid antibodies, and embolism. So here is the pictures to show that, which are all published one, ischemic stroke with multiple arterial distribution in a COVID case affecting the multiple artery territory. These are the microhemorrhages in the brain associated with COVID-19. Then you have a massive strokes which are occlusion and producing even a multiple hemorrhagic transformation in an ischemic stroke, and venous occlusion as you see in the transverse sinus as well as sigmoid sinus, giving rise to the massive venous occlusion or venous thrombosis, which is very well known in case of COVID-19. And you have seen here CT angiograms which you have demonstrated, definitely a big thrombus. And then watershed infarcts are very well known, multiple infarcts are known, and the patient can come to us suddenly in a ward with the COVID-19 patients. How many times the neurologists are called to the COVID ward saying that the patient has developed an acute stroke, especially in a cytokine storm phase of the illness. And that is what exactly was required to know. The COVID can cause encephalitis, which is, problem here is the encephalitis and alteration in sensorium, but the mortality is very high. 13.4% can have mortality with encephalitis. Symptomatic treatment, various treatments have been used for the COVID-19 encephalitis, but unfortunately the neurological dysfunction may persist and it may go on even after longer time with a cognitive impairment. That is what is very, very important. Patient may recover, but we may land up with a severe cognitive impairment, and that is what is very, very important. Encephalitis could be in the form of ADEM, it could be in form of acute neurological hemorrhagic encephalitis, limbic encephalitis, viral encephalitis, and multisystem involvement. Here are some examples of a 24-year male, fever, loss of consciousness, generalized seizure, neck stiffness. We all see this. Cerebrospinal fluid demonstrated SARS-CoV-2, and this is encephalitis. Here is, we have the acute disseminated encephalomyelitis. As you can see in the brain as well as in the spinal cord, we could see this demyelination. And I'm sure the organizers included this because of that, possibly in a demyelination segment where they have demyelination is one of the important manifestation in presentation of COVID-19. Even have acute necrotizing hemorrhagic encephalitis. That is another manifestation which we can see as it is demonstrated in this picture. COVID can produce myelitis. Transverse myelitis is very well known. And one of the common features of the transverse myelitis, which is usually para or post-infectious. Most often it is a post-infectious rather than the para-infectious. And just Dheeraj was showing about the long-term, the LTEM. And this could be seen in case of COVID. And that is what exactly we all seen in our practice, the long segment demyelination occurring in a case of COVID-19. And that is one is important. But he clearly mentioned that it is never acute. And that is the point which is very, very important. These are not acute. And this is acute, that NMO is not acute. Then COVID myelitis occurs in about 1.2% as a neurological complications of the coronavirus. And this most probably for post-infectious variety. GBS, I'm sure all of you have seen the cases of Guillain-Barré syndrome, and you are continuing to see some of these cases. There are about 220 patients have been reported already, and these are even isolated. SARS-CoV-2 has been isolated in the GBS. And these are important to know because in future we may have many other coronaviruses which can produce the neurological manifestation. Para-infectious nature. Most often the GBS here is para-infectious with pleocytosis in the CSF. And most probably we have to see the pictures, and you can see here very nicely demonstrated root enhancement. The patient may have radicalitis with a tingling paresthesia, burning pain, allodynia, and denervation on the EMG, but they respond very well to the IVIG. That is very important. Miller-Fisher syndrome. We have seen patients with Miller-Fisher syndrome with COVID-19. Ophthalmoparesis from cranial nerve palsies are very well known. I don't want to go into the details about certain associated conditions which are in multiple sclerosis, myasthenia gravis, and others. So because I want to talk about something on vaccine, that is why I'm leaving this because of the shortage of the time we'll have. Now I will not talk about the epilepsy, but most important is COVID can produce myositis. And myositis is very well known. Here is a 58-year woman, ptosis, facial paralysis, dysarthria, proximal muscle weakness. CPK was 700. They treated with methylprednisolone, improved in 2 weeks' time. But what you see in MRI, severe myonecrosis. And muscle biopsy clearly shows the inflammatory infiltrates and regenerating fibers exactly like polymyositis. So viral myositis, we all know the COVID can produce a myositis which is exactly like polymyositis type of picture. And you all heard about mucormycosis. We have heard about mucormycosis, but suddenly there was a large number of mucormycosis with the COVID-19. What was the problem? The mucormycosis was predominantly seen in the males, and in both people were active and recovered patients from COVID-19. And what was the cause? Diabetes mellitus was present in 80% of the patients. And another important feature is diabetic ketoacidosis, which we all aware of it. And then corticosteroid therapy, indiscriminate use of corticosteroids during the COVID time. We all know that the patients have received large doses of the steroids. And what has happened? That has resulted in mucormycosis involving the nose and sinuses in 8.9%, and it is also followed by orbit involvement. What is unfortunate is 1/3 of the patients succumb to this, and this was because of the indiscriminate use of corticosteroids on the background of COVID-19, which has resulted in mucormycosis. Fortunately, we have learned very quickly and changed the picture. So what we need to know is, in future, you should be careful what to use and what should not be used. Otherwise, we are resulting in many more problems. Post-COVID, we also seen large number of patients coming with a post-COVID syndrome. We call that as a long haul. And the patients come to us repeatedly in the neurology OPD with various symptoms. What are those symptoms? Mainly fatigue, memory and concentration disorder, which is very well known, headache, pain, insomnia, anxiety, and depression. The last point, which has to be emphasized with anxiety and depression, especially in those patients who have gone through a bad patch with ICU, coming out, they have severe anxiety and depression where you need to work with your psychiatrist colleagues. That is what is very important. We added, from our own experience, one of the important features, which is the post-COVID pontine myelinolysis. We saw the patients with 3 cases of post-COVID pontine myelinolysis, which is very clearly demonstrated here. In all the 3 cases, the patient has been treated for hyponatremia, and after 4 weeks, when everything is corrected, slow correction, everything was taken care, patient come back with pontine myelinolysis. But what is important is they responded to IVIG, and all 3 patients have recovered, and they are still coming for follow-up, and repeated MRI has shown complete clearance. And this is being published shortly, and these 3 cases details are very clearly known. So central pontine myelinolysis is one of the things which we added to this. What are the guidelines for the management? Neurologists should be involved early in the care, especially in ICU patients. Acute stroke, you used electrolytes because it can be given very rapidly rather than alteplase, which takes longer time. IVIG should be used rather than steroid, and immunosuppressive therapy should be carefully be used. And some of the patients like Parkinson's disease, many of our patients, ALS, have presented with respiratory difficulty during this COVID-19. Dementia patient may not report even. These are the problem, and this slide shows summary of neurological manifestation. I'm not going into this. I will just jump on to, in the last 3-4 minutes, neurological complication associated with COVID vaccination. This is important now because India has successfully given 200 crores of vaccination. What was the problem? Is there any problem? We have vaccine-induced problems. Everybody knows about it. But what should be known here is whether COVID vaccine has caused any problem. We have newer generation of vaccines now, DNA-based vaccine, mRNA-based vaccine, protein-based vaccine, unlike the previous first generation vaccine, where we have used live attenuated vaccine and also live vaccine. These were replaced now by the vaccines which are of the recent generation. Whether these vaccines also has any problem. There are some problems with the vaccination also, but it is very, very small number. So the most common neurological symptoms were minor, comprising of dizziness, headache, pain, muscle spasm. All these things we are aware of it. But my attention was diverted because I lost my own family member with vaccine complication very right in the beginning, in the March 2021, with Whippet syndrome. When I learned after that, because nothing was known during that time, and that's why my attention was diverted to the vaccine and vaccine-related problem, we should look at it. The major complications are stroke, GBS, facial palsy, cerebral venous thrombosis, Whippet syndrome, which is very, very important, then transverse myelitis, and acute disseminated encephalomyelitis. And this can be classified as brain involvement, spinal cord involvement, cranial nerve involvement, peripheral nerve involvement, and muscle involvement. All are known with the vaccine, but it is still a very small number. There are literature which has been published, and these are the compilation of the literature. From India, there is only one publication from Kerala which has been talked about the GBS in 7 patients. But what is important is we can see cerebral venous thrombosis is one of the common manifestation which is very well known. And the Whippet syndrome, where hypothrombocytopenia was recognized, and you should not give platelets in them. You have to give IVIG to them. That is a very, very important. Is the vaccine complications are occurring now also? Yes, even now today, I have a patient with a GB syndrome right now in the ward with a vaccine-induced complication. Can we attribute to this vaccine? Anything criteria is now 3 weeks after the vaccine was given. If there are neurological complications, it is attributed to the vaccine. And that is the criteria which has been given. And here is a publication which has been published in Annals of Neurology from USA, which is a neurological events reported after COVID-19 vaccine and analysis of vaccine adverse event reporting system. They have collected the information from every person who has administered the vaccine with the demography and got all the details. It is runs into 300,000 patients which have been taken, and hence it was distributed, and this data was analyzed by us also. Hence we are also part of this publication in Annals of Neurology which has come. And what it says is very important in an abstract. It is known in a very small proportion, 0.1%. So don't be worried about it. We have given 200 crores, but it is only in 0.1% of the vaccine-related complications are known. And then it is only in 0.03%, it is the neurological complication. And the reports of the serious neurological event following COVID vaccinations are rare. GBS syndrome, CVT, and seizure may occur at a higher than the background rates compared with following Johnson vaccination, M protein vaccination, and also mRNA vaccination. It is also seen with our own Covaxin as well as Covishield. It has been known. What is important is, despite this, the last sentence is extremely important, and hence I want to emphasize the neurological complications following the COVID SARS-CoV-2 is 617 times higher than the vaccine. So don't be afraid about the vaccine. So many people have come and asking for the vaccine. In our own family, when a person died, his wife came and took the vaccine. And that is what is very, very important. So we must know that vaccine is very, very important. But at the same time, as a neurologist, vaccine-associated neurological deficits are known as in any other vaccines, and we should be aware of it. Do we have any publications? Yes, we have a publication of 20 cases which has already been accepted in Journal of Clinical Neurology, which is coming in November of this year. And that publication shows the vaccine involved both Covishield as well as Covaxin. And very interestingly, we have seen even CIDP. 3 cases of CIDP has been seen, and they respond very well. What is important is identification early and starting the appropriate treatment really helps. And IVIG and steroids are the mainstay in the treatment. But you must be careful in using these immunomodulators, when to use it and how much you use it. And in a Whippet syndrome, don't ever give the platelet transfusion, but give IVIG. And that is the message in my presentation, to talk about the problems of COVID, which we have gone through. And fortunately, it is ending today. And that is why I think Medanta is able to do a physical conference after the gap of 3 years, and we are all happy to meet here in this hall without a mask, or some people are wearing the mask. And that is why we need to fight together for this entity. But don't forget that COVID may go on, but another coronavirus might come, and knowledge acquired through this COVID-19 will be helpful in future for tackling future infections. Thank you very much.
Thank you, sir. Any questions or any comments? Wonderful talk. Please. Request you to use the mic here.
So, your lecture has been eye-opener to me, Sir Dr. Chandra. In last 2 months, I have almost seen 20 cases of sinus thrombosis in large number, and I have treated them with uh, anticoagulants and anti-edema measures. Should we use steroids in all the cases?
I didn't understand the question. Can anybody?
Cavernous sinus thrombosis, overall sinus thrombosis, very common complication which we are seeing these days.
Sinus venous thrombosis is very well known with the COVID, but the criteria are very, very clear. It should be RT-PCR positive and in the presence of the COVID infection when it is occurring. And if you have that along with the sinus venous thrombosis, then we have to attribute to that. But we need to rule out other causes which may be responsible for that.
Role of steroids in such cases?
Role of steroid in CVT.
Yeah.
So role of CVT definitely not there. Why do you want to give steroids? You can use a short dose of mannitol. Please be careful when you are using the steroid in a case where it is not indicated.
Thank you.
Yeah.
Yes.
One more. Yeah.
Please.
Thank you so much, sir. Actually, I just want to thank you for imparting such a great knowledge to all of us because was the victim of COVID-19 in second phase because I got rebirth. Actually, I was in a very bad condition. Thank you so much. Thank you so much, sir.
Thank you.
Thank you. So we close this session. We can close the session, sir. Thank you to all the speakers.
Thank you so much, sir, Dr. C.S. Agrawal, Dr. Anjani Sharma, and Dr. Atul Prasad for having such an interactive and engaging session.